Welcome to the Hospital Medicine Unplugged podcast.
Today we are undertaking, I think, a really critical deep dive into managing acute infective endocarditis, i.e. in the hospitalized patient.
Yeah, this is definitely one of those diagnoses that demands, everything moving fast and correctly. We're talking about pulling together evidence from ACC, AHA, IDSA guidelines, key literature.
Right, because the stakes are incredibly high, that urgency. It's driven entirely by the prognosis.
It really is. I mean, you're looking at a disease with just devastating mortality, 15 to 20% in hospital, which is bad enough, but then it jumps to nearly 40% at the 1-year mark.
40%. It's sobering.
So our mission today is really to distill all that consensus, the guidelines, the literature, into, actionable steps, things you can actually use at the bedside, focusing on rapid diagnosis, stabilization, getting the antibiotics right, and that really tough call on surgical intervention.
Okay, so maybe let's start with the basics, just to ground everyone. The definition and the epidemiology, because honestly, the landscape of IE has shifted quite a bit.
Yeah, good point. So acute IE, we're talking about a rapidly progressive infection, right? Hitting the endocardial surface valves mostly, but sometimes the lining of the heart itself.
And characterized by that sudden onset, the high fever, sometimes rigors, just systemic toxicity, and crucially, the swift development of major complications.
Things like valvular failure, heart failure, throwing clots, embolization, or even heart block if it extends into the conduction system.
Exactly. And the numbers, you mentioned the shift.
Yeah, the incidence, it's somewhere between, say, 3 to 15 cases per 100,000 per year, but definitely trending up, especially in industrialized nations.
And we're seeing it more in older patients, right?
Mm-hmm.
Over 65 seems to be the highest risk group.
Definitely. Age is a big factor, and also male gender, the ratio is often more than 2 to 1. Plus, these older patients often bring a whole host of complex comorbidities to the table.
Which complicates everything, of course. But maybe the most crucial shift, clinically speaking, is the bug itself, the etiology.
Right. Staphylococcus aureus, it's now the undisputed #1 cause of native valve endocarditis, NVE, in high-income countries.
And that is a game changer, because S. aureus is just so much more virulent, more destructive than the historical bugs like Viridans, group strep. It demands a much more aggressive approach right out of the gate.
And then there are specific risk factors tied to certain presentations. Prosthetic valve endocarditis, PVE, that often involves coag-negative staph, sure, but we also have to talk about IV drug use.
Absolutely critical point. The opioid epidemic has fueled a huge rise in IE cases, particularly in younger populations.
And that IVDU population often presents differently, doesn't it?
It does, typically right-sided, i.e. hitting the tricuspid valve most often. And the bug is almost always S. aureus.
Including MRSA, methicillin-resistant S. aureus?
Frequently MRSA, which means vancomycin coverage up front is basically non-negotiable in that population. And the whole management path is complicated by the underlying addiction, the social factors, the very high risk of reinfection, even if you fix the valve. It's a huge challenge.
Okay, so understanding that epidemiological shift, the rise of Staph aureus, the IVDU connection, brings us right to that first crucial phase, initial diagnosis and stabilization. What are the absolute red flags, the things that should make you immediately think this could be acute, IE?
Well, fever is almost always there, up to 90% of patients, often with those non-specific things like chills, malaise, maybe some muscle aches.
But the cornerstone finding, the one you really listen for.
It's the new or changing heart murmur. That's present in about 3/4 of patients, and it really signifies active, ongoing valve damage. That's the finding that should, really raise the alarm.
And I think it's worth emphasizing what not to rely on, right? We all learned about the classic peripheral signs in med school.
Oh, absolutely. We have to hammer this home. Osler nodes, Janeway lesions, Roth spots, splinter hemorrhages, these are uncommon in the acute setting, less than 10%.
So waiting for those to show up.
It's a critical mistake. It delays diagnosis, maybe fatally. You're waiting for a sign that only 1 in 10 patients might have, while their valve is literally being destroyed. The trigger has to be fever, systemic illness, and that new or changing murmur, period.
And while you're doing that initial assessment, you have to be triaging for complications simultaneously. What's the #1 killer we need to look for immediately?
Acute congestive heart failure. It's the most common and the most lethal complication, usually from sudden severe valve regurgitation, aortic or mitral typically.
So any sign of pulmonary edema, shortness of breath, hemodynamic instability in a patient who looks septic.
IE needs to shoot right to the top of your differential. And you need to be getting urgent cardiology input and planning for imaging, like right now.
Okay, beyond heart failure, what's the next big category of disaster?
Neurologic complications, strokes basically, both ischemic from emboli and hemorrhagic, often from a ruptured mycotic aneurysm. Brain abscesses too.
And that happens pretty often.
Yeah, somewhere in the range of 15 to 20% of patients. The risk is definitely higher with S. aureus, it just loves to spread, and also with large mobile vegetation seen on echo.
Which makes diagnosing it quickly paramount, because a stroke really impacts decisions down the line, especially around surgery timing.
Exactly, so that leads us straight into the diagnostic workup. Speed is everything.
Right.
What's the absolute first step, the non-negotiable?
Microbiology first, before any antibiotics touch the patient.
Cannot stress that enough. You need at least 3 sets of blood cultures from separate venipuncture sites, not just drawing 3 tubes from one
So
sniff.
volume matters, right? You can't just get a small draw.
Critically important. Minimum 20 milliliters of blood per set. Usually that means 10 mils into the aerobic bottle, 10 mils into the anaerobic. You need that volume to pick up potentially low levels of bacteremia.
And if those cultures come back positive for the usual suspects?
Like S. aureus, strep species, Enterococci, or that HAC group. That counts as a major due criterion right there. Helps solidify the diagnosis quickly.
Could you just quickly remind us what HAC stands for? They're kind of unusual bugs.
Sure. It's an acronym for a group of fastidious, meaning slow-growing, gram-negative rods, Haemophilus, Actinobacillus, now Aggregatibacter, Cardiobacterium, Coxiella, and Kingella.
And why are they specifically called out in Duke criteria?
Because they're known causes of endocarditis, often subacute, but they can be tricky to culture. So isolating one of them carries significant weight, even if it takes the lab a bit longer to grow them.
Okay, cultures are sent. What's the next step? Imaging. We start with TTE.
Right. Transthoracic echo is the first go-to. It's non-invasive, readily available. Its sensitivity is decent for native valves, maybe around 70%.
But the big limitation is?
Prosthetic valves. Sensitivity drops off a cliff, often 50% or even less. Just too much acoustic shadowing and artifact from the hardware.
So if that TTE is negative, or maybe it's just unclear, but you still really suspect IE?
Then transesophageal echocardiography, TAE, is mandatory. You have to proceed to T.
No question about it, because the sensitivity is way higher.
Upwards of 95%. But it's not just sensitivity. TE gives you vastly superior anatomical detail.
Which is crucial for looking for those really bad complications, right?
Exactly. TE is the gold standard for diagnosing paravalvular extension, meaning the infection spreading beyond the valve leaflet into the surrounding tissue. Abscesses, fistulas, prosthetic valve dehiscence. TTE often misses these completely.
And finding those things often tips the scale heavily towards needing surgery and needing it soon.
Absolutely. They are major surgical indications.
What about other imaging? Is there a role for CT or PET scans?
Yeah, becoming increasingly important, particularly as adjuncts. CT scans are great for looking for embolic phenomena systemically, like in the spleen or kidneys, or critically in the brain.
And PT-CT?
PTT has really found a niche in prosthetic valve endocarditis, especially if the T is equivocal, or maybe it's early post-op and there's a lot of inflammation anyway. PT can light up areas of active infection or inflammation around the valve that other imaging might miss.
So while all this diagnostic testing is happening in parallel, often very quickly, the patient might be quite sick. Hemodynamic stabilization is key.
Priority 1.
Yeah.
ADCs, airway breathing circulation. If they're hypotensive or in shock, aggressive IV fluids, vasopressors as needed, standard resuscitation.
But with a crucial difference in IE.
Right. The source of the shock might be mechanical failure. The valve is acutely failed. So medical management alone might not be enough.
Meaning?
Meaning early consultation with cardiology and, importantly, cardiac surgery is not just a formality, it's part of the stabilization process. You need to know urgently if this patient needs a surgical fix to survive.
And one more critical point during this initial phase anticoagulation, if the patient is on, say, warfarin.
The ACC guidelines are pretty clear here. For native valve endocarditis, unless there's a very compelling reason otherwise, you should stop vitamin K antagonists like warfarin at presentation.
Why is that?
2 big reasons. 1, the risk of hemorrhagic conversion if they throw an embolic stroke is significantly higher on anticoagulation. 2, many of these patients need urgent surgery, and reversing warfarin takes time and can be complex, so the default is to hold it.
Okay, let's pivot now to antibiotics. Cultures are drawn, patient is maybe unstable, or your suspicion is super high. How quickly do we start empiric therapy, and what are we aiming to cover?
You start immediately after cultures are obtained, especially in unstable patients. Don't wait. And the empiric coverage needs to hit the big three likely culprits based on modern epidemiology,
Which are?
Staphylococcus, and you must cover MRSA, Streptococcus, and Enterococcus.
So what's the standard go-to empiric regimen for suspected native valve, i.e. that covers those bases?
The consensus regimen is vancomycin plus ceftriaxone
Okay, let's break that down. Vancomycin for...
for reliable MRSA coverage, and it also covers MSA and many strep species. We typically dose it aiming for an initial trough level of maybe 10 to 15 micrograms per milliliter, although we'll talk about AUC monitoring later for directed therapy.
And the ceftriaxone.
Ceftriaxone brings excellent coverage for most streptococcus, including Viridans group and S. gallolyticus, formerly bovis, plus some enterococcus, though not usually resistant strains. And it has some synergy. The dose is typically 2 grams Morve once daily.
Now, we need to adjust based on risk factors, right? You mentioned IVDU.
Absolutely. If the patient is an IV drug user, vancomycin is non-negotiable due to the high prevalence of MRSA in that population. That has to be part of the empiric regimen.
What about prosthetic valve endocarditis, PVE? Does the empiric regimen change?
It often does, yes.
Yeah.
PVE is generally considered higher risk and potentially involves different or more resistant organisms, especially if it's early PVE, occurring within the first year after surgery.
So what would you add or change for empiric PVE coverage?
You'd still start with vancomycin and ceftriaxone, but guidelines often recommend considering the addition of gentamicin and potentially rifampin, especially if you strongly suspect a staphylococcal PVE.
Okay, gentamicin and rifampin. Why add those specifically for prosthetic valves? What's the thinking there?
It's all about the biofilm. Bacteria, especially staph, form biofilms on prosthetic material very readily. Biofilms are like protective shields that make it hard for antibiotics to penetrate.
And rifampin is good at.
Rifampin is one of the few antibiotics that penetrates biofilm well and can kill the less metabolically active bacteria hiding inside.
And gentamicin.
Gentamicin provides rapid, synergistic bactericidal killing, particularly against staph and enterococcus. The idea is a multi-pronged attack to sterilize that infected hardware quickly.
But there's a big downside to gentamicin, isn't there?
Huge downside: nephrotoxicity and ototoxicity, especially over a prolonged course or in patients who already have kidney issues or are elderly. So adding gentamicin is a serious decision, weighing that benefit against significant potential harm. It's often used only for the first couple of weeks, if at all.
All right, so that's empiric therapy. Hopefully within 48, 72 hours, the lab calls with an ID and susceptibilities. Now we move to directed therapy. The duration is usually long, right?
Typically 4 to 6 weeks, sometimes longer for complicated cases or PVE. And crucially, that clock, the 4 to 6 weeks, starts from the first day of documented negative blood cultures, not from the start of antibiotics.
That's a key point. You need proof the bloodstream is clear before you start counting down the duration. And tailoring this directed therapy really requires expertise, doesn't it?
Absolutely. Infectious diseases consultation is strongly recommended, borderline mandatory, for all cases of endocarditis to ensure the regimen is optimized, dosing is correct, duration is appropriate, and monitoring is in place.
Okay, let's run through some common pathogen-specific regimens, assuming we have susceptibilities. What about the classic bugs, Viridans group, strep, or S. gallolyticus, assuming they're penicillin susceptible?
If they're fully penicillin susceptible, low MIC, the classic treatment is high-dose penicillin G. We're talking 12 to 18 million units per day, given IV usually in 4 or 6 divided doses for 4 weeks.
That's a lot of penicillin and frequent dosing. Is there a simpler option?
Yes. Ceftriaxone 2 grams the IV once daily for 4 weeks is considered an equivalent and often preferred alternative due to ease of administration. Much easier for outpatient therapy too, if that becomes an option later. The gallolyticus is really only for severe beta-lactam allergies here.
Okay, moving on to a tougher customer. Enterococcus. They often have resistance issues. What's the preferred approach, especially if you're worried about aminoglycoside resistance or toxicity?
Enterococcus definitely needs synergy. 2 drugs are better than 1. If there's high-level resistance to aminoglycosides, or if the patient has kidney problems or is elderly, the preferred regimen now is often the dual beta-lactam combination.
Which is?
High-dose ampicillin, 12 grams per day, 3 Phe, usually divided every 4 hours, PLUS, High-dose ceftriaxone, 2 grams the vial, but
Right.
given every 12 hours in this case.
Ampicillin plus ceftriaxone, how does that work synergistically?
They target different penicillin-binding proteins in the enterococcal cell wall, leading to enhanced killing compared to either drug alone, and you treat for 6 weeks with this combo.
What about the older regimen, ampicillin plus gentamicin?
Still an option if the strain is susceptible to both and the patient can tolerate gentamicin. But given the nephrotoxicity risk over a 6-week course, many experts now lean towards the ampicillin-ceftriaxone combo, if possible, especially in vulnerable patients.
Makes sense. Now the big one, Staphylococcus aureus. Let's start with MSSA methicillin susceptible. What's the drug of choice?
The gold standard remains an anti-staphylococcal penicillin, nafcillin or oxacillin. Again, high dose 12 grams per day 4, divided every 4 hours for a full 6 weeks.
Why nafcillin or oxacillin over, say, cefazolin or Ansef?
While cefazolin is an alternative, especially for mild non-anaphylactic penicillin allergies, nafcillin and oxacillin are generally thought to have slightly better activity against MSSA, particularly in penetrating vegetations and biofilms. So they remain preferred if tolerated.
Okay, and for the dreaded MRSA, we mentioned vancomycin for empiric coverage.
Vancomycin remains the primary treatment for MRSA endocarditis. Dosing needs to be aggressive, often 30 to 60 milligrams per kilogram per day, divided into maybe 2 or 3 doses. Treat for 6 weeks.
But you mentioned therapeutic drug monitoring has changed. We're not just looking at troughs anymore.
Correct. This is a really important practice shift. Guidelines now strongly recommend moving away from solely monitoring trough levels and instead targeting an area under the curve, AUC, over 24 hours. Specifically, aiming for an AUC to MIC ratio, which usually translates to a target AUC of 400 to 600 microgram hours per milliliter.
Why switch from troughs to AUC? What does that achieve clinically?
It's about better predicting both efficacy and toxicity. Vancomycin's killing is related to the total exposure over time, the AUC, not just the lowest point, the trough. Troughs are actually a pretty poor surrogate for overall exposure.
So aiming for that AUC target.
It helps ensure we're giving enough drug to effectively kill the MRSA over the full 24 hours, while potentially minimizing the risk of acute kidney injury, which is a major concern with prolonged high-dose vancomycin. It's a more precise way to optimize therapy. Requires pharmacy support, obviously, to calculate.
And if vancomycin isn't an option, maybe allergy or rising MICs or kidney injury develops.
The main alternative is high-dose daptomycin, typically 10 milligrams per kilogram IV once daily for 6 weeks. It's crucial to use that higher dose. The 6 millikilogram dose used for skin infections isn't enough for bacteremia or endocarditis.
Good clarification. Any special considerations for prosthetic valve staph infections?
Yes. For staphylococcal PVE, whether it's MSSA or MRSA, guidelines recommend combination therapy, usually vancomycin or nafcillin for MSSA, PLOS rifampin for its biofilm penetration, PLUS gentamicin for synergy, at least for the initial 2 weeks. Therapy duration is usually at least 6 weeks, often longer, and rifampin is typically continued for the entire course.
Okay, one more antibiotic topic before surgery, the idea of switching to oral therapy. The POET trial generated a lot of buzz. Is this something we can routinely do now?
Routinely, no. Selectively, yes, but with extreme caution. POET was a landmark trial showing non-inferiority for switching to oral antibiotics in very specific stable patients.
What are those stringent criteria? Who is even potentially eligible?
Okay, key things. Has to be left-sided endocarditis. Patient must be clinically stable. No signs of complicated infection, no abscess, no fistula, no heart block, no major emboli. Vegetation size usually needs to be under 10 millimeter.
What else?
The bug has to be susceptible to highly bioavailable oral agents, typically strep, enterococci, or S. aureus. And critically, the patient must have already completed at least 10 days of effective IV therapy, documented bloodstream clearance, and have reliable means for close follow-up, including monitoring drug levels if needed.
So this isn't a decision made lightly or by one person?
Absolutely not. It requires full multidisciplinary team, buy-in ID, cardiology. Often the heart valve team surgeons need to agree it's safe, and you need robust social support and patient adherence. It's an option for a select few, not a standard pathway.
That multidisciplinary team involvement really brings us to the next major section, surgical intervention. Guidelines are emphatic about the need for a dedicated multidisciplinary heart valve team to make these decisions. Why is that team approach so critical in IE?
Because the decision to operate or not operate on a patient with active endocarditis is incredibly complex and has profound prognostic implications. The data is very clear. Patients who meet guideline criteria for surgery but don't get it have significantly higher mortality, both in hospital and at 1 year.
So who is on this team, typically?
It should include cardiology, cardiac surgery, infectious diseases, and cardiac imaging specialists, echo, CT, etc. They bring all the different perspectives needed to weigh the risks and benefits.
What are those risks and benefits? What are they balancing?
They're balancing the severity of the cardiac damage, how bad is the valve leak or failure, the control of the infection, is it spreading, are antibiotics working, the risk of embolization, and importantly, the patient's overall condition and operative risk. Can they physiologically tolerate major heart surgery right now?
Okay, let's get specific. What are the major indications for early surgery, meaning operating during the initial hospitalization, often while still on antibiotics?
There are basically 3 major categories. First, and probably most common, is hemodynamic deterioration or heart failure.
Meaning?
Severe acute aortic or mitral regurgitation that's causing refractory pulmonary edema or cardiogenic shock. The valve is just destroyed and medical management is failing. The only fix is surgical.
So medical therapy for HF in this setting is just a bridge.
Exactly. It buys you maybe hours or a day, but it won't fix the underlying mechanical problem. That requires valve repair or replacement urgently.
Okay, category number 2.
Uncontrolled infection. This means the antibiotics aren't working well enough on their own.
How do we define that clinically?
The clearest sign is persistent bacteremia or fever for more than, say, 5 to 7 days, despite being on appropriate targeted antibiotics. It implies the infection is too deep-seated or maybe resistant.
And are there imaging findings that scream uncontrolled infection?
Yes. Evidence of paravalvular extension on T is a huge one. Seeing an abscess forming around the valve ring, a fistula tract developing, or prosthetic valve dehiscence, and critically, the development of a new heart block.
Why is new heart block such an ominous sign?
Because it means the infection has eroded from the valve annulus directly into the heart's electrical conduction system nearby. Antibiotics alone almost never cure that. It requires surgical debridement. That's an urgent surgical indication. Also, infections caused by fungi or highly resistant bacteria often fall into this category.
Makes sense. And the third major category for early surgery?
Prevention of systemic embolization, basically trying to prevent a stroke or other major embolic event.
What features put someone at high enough risk for embolization that you'd operate prophylactically?
The main factors are vegetation size and mobility. Large vegetations, typically defined as greater than 10 millimeters, especially if they look mobile or floppy on echo. The risk is even higher if the patient has already had one embolic event while on therapy.
So one embolus plus a big vegetation often equals surgery?
Often, yes, especially with high-risk bugs like S. aureus or fungi. Also, vegetation location matters. Ones on the anterior mitral leaflet seem to have a higher risk of embolizing to the brain. So the team weighs all these factors.
Okay, we have the indications. Now, the really tricky part, timing.
Yeah.
When do you pull the trigger? Emergency? Urgent?
Right. Emergency surgery, meaning within 24 hours, is reserved for true hemodynamic catastrophes. Rapidly progressive heart failure, cardiogenic shock refractory depressors, maybe valve rupture causing cardiovascular collapse, life or limb situation.
And urgent surgery?
Urgent, usually defined as within about 7 days, covers most of the other clear indications we just discussed. Things like a diagnosed abscess, uncontrolled bacteremia despite a few days of antibiotics, or that high embolic risk profile, large vegetation plus prior embolus.
What about the really complex scenario? The patient has, i.e., meets criteria for surgery, but they've also just had a stroke due to an embolus. How does that affect timing?
That's probably the toughest call the heart valve team makes. You're balancing the need for heart surgery against the risk of worsening neurological injury if you operate too soon after a stroke, especially if there's any hemorrhagic conversion.
So what are the general guidelines there if it was an ischemic stroke?
For an uncomplicated ischemic stroke, generally small to moderate size without hemorrhage, the consensus is often to wait about 7 days if possible to allow the brain inflammation to subside before going on cardiopulmonary bypass.
And if it was a hemorrhagic stroke or an ischemic one with hemorrhagic conversion?
Then the waiting period is usually longer, often needing to delay surgery for 14 days or even more to minimize the risk of rebleeding during bypass, which requires heparinization.
But what if the patient is also in severe heart failure? Does the stroke timing rule still apply?
No. Life-threatening refractory heart failure due to valve destruction always trumps the stroke timing concerns. If the patient is dying from cardiogenic shock, you have to operate immediately, regardless of the stroke window.
And just manage the neurological risk as best you can perioperatively.
Exactly. It's a high-risk operation, no question. But you can't let the patient die of heart failure while waiting for the brain to heal. That's where risk stratification tools, like the Society of Thoracic Surgeons, STS, endocarditis score, can help the team quantify the operative risk and counsel the family.
Okay, so while we're making these complex decisions about surgery, or maybe managing someone who isn't a surgical candidate, we have to deal with the complications. Let's revisit heart failure.
As we said, HF from valve destruction is the main driver of mortality. Initial management is standard diuretics, maybe afterload reduction if blood pressure allows. But you have to constantly remember this is just buying time.
The definitive treatment is fixing the valve.
Absolutely. Trying to manage severe HF medically long-term in this setting is associated with extremely high mortality. Surgery is required if feasible.
What about managing emboli? We know the risk is highest early on. Does it decrease with treatment?
Yes, significantly. The risk peaks in the week or two before diagnosis and then drops off considerably within the first 1 to 2 weeks of effective antibiotic therapy as the bacterial load decreases and the vegetation starts to stabilize or shrink.
But surgery can still reduce future risk.
Correct, especially in patients with those persistent large vegetations or those who've already embolized once. Removing the source is the best prevention.
And let's just hammer home the anticoagulation point again, especially after an embolic stroke.
Generally avoided in acute native valve, i.e., the risk of hemorrhagic conversion of an ischemic stroke is just too high. If anticoagulation is absolutely essential, like for a mechanical valve, it needs incredibly careful management, maybe bridging with heparin, but the default is no anticoagulation.
Okay, local extension abscess, fistula, heart block. We know T diagnoses them, and they usually mean surgery. Is there any role for antibiotics alone?
Very, very rarely, maybe for a tiny contained abscess that shows rapid improvement. But generally, no. These represent tissue destruction and deep-seated infection that requires surgical debridement and reconstruction. Finding these on T essentially confirms the need for urgent surgery.
And finally, kidney problems. We touched on this with gentamicin, but IE itself can cause renal dysfunction too, right?
Yes, multiple ways. You can get immune complex glomerulonephritis from the chronic inflammation and antigen load. You can get embolic infarcts to the kidneys. And of course, you can get acute kidney injury from the drugs we use, aminoglycosides, and vancomycin being the main culprits.
So management involves
Close monitoring of renal function, meticulous hydration, avoiding nephrotoxins whenever possible, adjusting doses of renally cleared antibiotics, and getting renal consultation involved early if needed.
All right, let's shift gears slightly to special populations who might need adjustments to these protocols. How about elderly patients?
The elderly are challenging. Presentations can be atypical. Less febrile maybe, more confusion or fatigue, leading to diagnostic delays. They have more comorbidities.
And we mentioned the antibiotic choice for enterococcus.
Right, in the elderly, the ampicillin plus ceftriaxone regimen is often strongly preferred for enterococcal, i.e. specifically to avoid aminoglycoside toxicity, which they tolerate very poorly. And of course, frailty has to be formally assessed and factored heavily into surgical risk assessment using tools like the STS score.
What about patients who already have significant renal dysfunction at baseline?
Similar principles. You have to be extremely cautious with nephrotoxic drugs. Minimize or avoid aminoglycosides altogether. Again, AMP ceftriaxone is preferred for enterococcus. Vancomycin needs careful AUC monitoring and dose adjustment. Sometimes alternative agents are needed.
And back to the IV drug use population, we know it's often right-sided, often S. aureus. What are the key management considerations beyond antibiotics?
The huge issue is the underlying substance use disorder. You absolutely need to involve addiction medicine specialists early on. Addressing the addiction is key to long-term success and preventing recurrence.
And how does the high risk of reinfection impact surgical decisions for, say, a destroyed tricuspid valve?
It complicates it immensely. Putting in a new prosthetic valve in someone likely to continue IV drug use carries a very high risk of that new valve getting infected. So surgical decisions are highly individualized. Sometimes repair is favored over replacement if possible. Sometimes surgery might even be deferred initially. Sometimes surgeons might opt for different valve types. It requires a very frank discussion about risks, benefits, and the patient's commitment to treatment for addiction.
Okay, so throughout this whole complex hospital course, what are the essential monitoring points?
Well, admission to a monitored setting is standard, ICU if they're unstable. Serial blood cultures are absolutely critical every 24 to 48 hours until you have documented clearance. That date of first negative culture is vital.
Do we need to repeat the echocardiogram routinely?
It's generally considered good practice to get a repeat echo. either TTE or TE, towards the end of the planned antibiotic course.
Why then?
To establish a new baseline after treatment, to see if vegetations have resolved or shrunk, to assess residual valve damage, and to make sure no new complications like an abscess have developed silently. This post-treatment echo is really important for long-term follow-up.
And one crucial discharge planning point.
Get the line out. Any PICC line or central line used for the long antibiotic course must be removed promptly at the end of therapy. Leaving it in is just asking for a new line infection.
Okay, final stretch. Secondary prevention and long-term follow-up. How do we try to prevent this devastating illness from coming back?
Patient education is paramount. They need to know the symptoms of relapse, recurrent fever, chills, night sweats, a new murmur if they can recognize it, new signs of heart failure, and they need to seek immediate medical evaluation if any of those occur.
Should they just take antibiotics if they get a fever?
Generally, no. We advise against empiric antibiotics for just any fever because it can muddy the waters if it's i.e. recurrence. They need evaluation, including repeat blood cultures first.
And long-term cardiac monitoring.
Yes, regular follow-up with cardiology is essential. Clinical exams and periodic echocardiograms as determined by the cardiologist based on the residual valve damage and clinical status.
You mentioned source control earlier. Dental hygiene seems key.
Hugely important, especially for strep endocarditis recurrences. Patients need rigorous, regular dental hygiene brushing, flossing, and routine professional dental evaluations and cleanings. Any potential source of bacteremia needs addressing.
What about antibiotic prophylaxis for dental procedures? Is that still recommended?
Yes, but only for specific high-risk patients undergoing specific high-risk procedures. The guidelines recommend prophylaxis mainly for patients with prosthetic heart valves, those with a previous history of endocarditis, certain complex congenital heart conditions, unrepaired or recently repaired, and cardiac transplant recipients who develop valvulopathy.
And only for dental procedures involving manipulation of gingival tissue or the periapical region of teeth or perforation of the oral mucosa.
Exactly. It's not for routine fillings or cleanings in most people anymore, but for those high-risk patients undergoing invasive dental work, prophylaxis, usually with amoxicillin, is still the standard of care.
And this long-term care requires a team too, right?
Definitely. It's multidisciplinary follow-up. Cardiology manages the valve function and heart failure. Infectious diseases may stay involved, especially if there were resistance issues or complex antibiotic needs. And the primary care physician coordinates overall care, monitors for recurrence, and reinforces prevention strategies.
Okay, so let's try to synthesize this. To summarize our deep dive, managing acute IE really boils down to hitting 3 critical phases hard and fast.
Right. Phase 1, immediate comprehensive blood cultures, 3 sets, right volume followed instantly by empiric antibiotics, usually vancomycin and ceftriaxone, covering the key players.
Phase 2, urgent T. Get that detailed look at the valve, quantify the damage, and crucially, look for paravalvular extension using the modified Duke criteria to confirm the diagnosis.
And Phase 3, early, decisive involvement of the multidisciplinary heart valve team. They need to evaluate for those core surgical indications, heart failure, uncontrolled infection, or high embolic risk, and make timely decisions about intervention.
It sounds straightforward on paper, but the clinical challenge is translating those criteria into action, especially when things get murky, like balancing stroke risk versus heart failure.
Absolutely. And given the persistently high morbidity and mortality, maybe we need to constantly reevaluate our own processes, especially in light of trials like POET, which support more aggressive initial management leading to stability.
Which leads to the provocative thought for today. Are we, as hospitalists, consistently underutilizing that formal heart valve team consultation early enough? Are we getting them involved proactively to properly triage patients?
Right. Triage either towards potentially life-saving urgent surgery when the criteria are clearly met, or conversely, are we identifying those truly stable, uncomplicated patients quickly enough, achieving source control, and then thoughtfully considering if they meet the strict criteria to potentially finish their long antibiotic course safely as an outpatient, mitigating the risks of prolonged IV access?
That initial guideline-driven decision by the team, operate now, manage medically, or plan for outpatient transition, really seems to dictate long-term survival for so many of these patients.
It often does. Getting that initial pathway right is paramount.